raise your hand if you're a first year. Okay. Raise your hand if you're a second year. Okay. Third. Okay. Fourth. Okay. All right. I'm Ginger Auer-Baker, Baker for short. I graduated from here. I did a body fellowship at Baylor in Dallas. It's a different Baylor than Houston or Waco. Anyway, I now work at the VA. If y'all rotate through there, then y'all should see me there. So we were a transplant center at Baylor, and we did a fair amount of this, but I will say that even researching this for this presentation, I learned a good amount that I didn't know that I was actually looking for, but was including in my reports in fellowship. So it's helpful to know this stuff. Anybody interested in body? Yes? Okay. You have any fellowship programs picked out? Yes? Where are you headed?
MD Anderson.
Oh, cool. Well, this should be helpful for you. Okay, moving on. So the learning objectives, we're just going to kind of talk informally about indications, contraindications, types of liver transplantation, main goals in preoperative imaging in both the recipients and in live donors. And then we'll talk about use of the different modalities briefly. Okay, so a lot of this is in question and answer format. Fourth year. Simon, you want to take it? Yes. The majority of this is geared towards adult transplantation, so. Okay. Hep B is the leading cause worldwide, but not in the United States. It's actually hepatitis C. In general, you have chronic liver disease, and then you have acute fulminant liver disease that can lead to the need for transplantation. Acute fulminant bumps you way up the UNOS list for transplantation because it's obviously much more pressing that you get a liver. So those people get livers first, and then you have the chronic liver disease patients. Of chronic liver disease, you have two main categories. You have cholestatic and non-cholestatic. So as the name implies, cholestatic are things that cause bile stasis, and that's how it leads to your liver disease. Whereas non-cholestatic is the disease kind of originates in the hepatocytes themselves. So the non-cholestatic causes of chronic liver disease are going to be your viral hepatitis, alcoholic liver disease, metabolic causes such as NASH is one of the up-and-coming things that looks like it could take over viral hepatitis and alcoholism because we're such a nation of obese people. Anyway, the non-cholestatic causes are way more common than the cholestatic causes. So in the United States, hepatitis C is the most common chronic non-cholestatic liver disease to lead to transplantation. Malignancy can also be an indication for transplantation. So which of these malignancies is not an indication for transplant? Give me a third year. Okay.
Which malignancy is not an indication metastatic?
Okay, true. And what about cholangiocarcinoma? Used to be a death warrant. Still kind of is, but there are a lot of facilities that do transplantation that are looking at transplanting cholangiocarcinoma patients. Not all of them are doing it. It's still being studied, so, but it's not an absolute contraindication now. Okay, so I don't want you to spurt out why you're answering the way you're answering, because we'll go over the Milan criteria shortly. But looking at this image, is this patient a candidate for transplantation? Second year.
I'd
Okay, just stop at no. Okay, another second year. Yes or no?
Yes.
Okay. Yes or no? I don't care who. Yes? Okay. So the answers were false, true, false. And going back over them, it's the size of this one. This one is true because it's small and it's singular. This one is false because you can have a maximum of 3 lesions, and there are 4. So there are at least 3 criteria that different institutions use, but UNOS, which are the people who create the list of who gets the organs in which order, they use the Milan criteria, so it's the most commonly used. So you can have a single tumor that's less than or equal to 5 centimeters, or up to 3 tumors that are equal to or less than 3 centimeters each. Okay, and this is UNOS.org. They have the computerized list. The list is generated based on a variety of things, not just how badly somebody needs it, but also how close do they live to where the liver is. So geography, and is the size of the organ that's available, does it fit the person who's next on the list? Okay, so this is to answer this question. UNOS uses the MELD score to determine severity of disease. The MELD score is a better predictor of mortality than the Child-Turcotte-Pugh score, and you calculate it using serum bilirubin, creatinine levels, as well as the INR. And if the score generated from that is over 12, then they also incorporate the serum sodium level, because low sodium levels is associated in patients with liver disease is associated with waiting list death for some reason. Okay, so a score of 15 or more, and this is variable depending on which resource you use. Well, actually not this. They say to refer for liver transplantation at either a score of 10 or 15, depending on which resource you use. But a score of 15 or less has a 3-month mortality of about 6%, while a score of 40 has a 3-month mortality of over 70%. And they kind of artificially just add 22 to your MELD score if you're diagnosed with hepatocellular carcinoma, because it bumps you up the list. Okay, I promise there were pictures at some point in this. They were all radiologists were like, where are the pictures? All right, contraindications, we're going to discuss these people on an individual basis. Some of the contraindications you can see and some you cannot, but it helps you to understand where the surgeons are coming from. So you have a 78-year-old male with a history of alcoholic cirrhosis and a MELD score of 10. He's sober for 5 years. Y'all think he's a candidate? No? Why not? He's old. That's a relative contraindication. It's not an absolute. But yes, it would make them raise their eyebrows. All right, 45-year-old female with a history of hep C and multi-substance abuse, recent admission with labs positive for cocaine and a MELD of 25. Okay, so her MELD is closer to needing a liver. Also, the 78-year-old, his MELD was way too low to need a liver. 45-year-old female, her MELD is closer to needing a liver, but if she's still using cocaine, they're not going to waste an organ on this person. All right, 33-year-old male, HIV positive, MELD of 35, and he has good family support system and psychosocial environment. What do y'all think? They will transplant this patient. It used to be an absolute contraindication, but now it is not, because they're now seeing that heart has basically turned HIV into a chronic disease, almost like diabetes. So they will actually transplant this patient. All right, 50-year-old female with hep C, stage 1 HCC, pulmonary hypertension, right heart dysfunction, and chronic medical noncompliance. No, correct. The stage 1 HCC would bump her way up the list, but if she has poor cardiopulmonary reserve, she's not going to withstand a 10-hour surgery, first of all, and then second of all, they're not going to waste a liver on somebody who's not going to be compliant. Okay. So this is just summarizing basically what we talked about. The one thing, well, these darker colored blue are the absolute contraindications. The lighter blue are the relative contraindications. So if you have extrahepatic malignancy or vascular invasion by HCC, then it's a contraindication. Active sepsis, I think that's for any surgery, unless they're trying to address like appendicitis or something. So severe cardiopulmonary disease, we talked about that. If they're very well compensated cirrhosis, then they don't need that liver right then. So that's where the MELD score comes into play. And then active alcohol or substance abuse issues. Okay, types: orthotopic liver transplant, living donor liver transplant, and split graft liver transplant. This one and this one are both cadaveric. So these are both organs from dead folks, and this is usually a friend or relative who wants to try to help out their friend or relative by giving them a portion of their liver. Okay, so for orthotopic transplantation, the role of imaging, like you have a deceased donor. So imaging is usually used to help determine if there are any absolute contraindications in the recipient. Those are the main things. For split graft, you're using one cadaveric donor liver and you're splitting it into two different livers. Usually they're taking the right lobe of the liver because it's larger and putting it in an adult, in the left and putting it in a smaller adult or a pediatric patient. Living donor, it's much more difficult to do the preoperative assessment because you have to assess the suitability of both the donor and the recipient. So we're going to spend more of our time on the living donor. But this is a brief surgical overview. I'm going to show you the picture and we can talk about it. One of the main differences, you're always going to take out the liver and the recipient, of course, and you're always going to take out the gallbladder. They ligate the vasculature in the bile ducts close to the liver. The main difference in when somebody is receiving a cadaveric liver compared to a living donor graft is they take the IVC when they do the hepatectomy, they take the recipient's IVC because they can take the IVC from the cadaver. So that's the main difference. So when you're doing the preoperative imaging, you evaluate the liver parenchyma. You look for intra or extrahepatic malignancy. Is there any lymphadenopathy? Now, when you start reading these cross-sectional images on these patients with HCC and those who have just Hep C or Hep B and don't have HCC, you notice that everybody has enlarged lymph nodes, it seems. Celiac, portocaval, portohepatis, and the great majority of the time they're just benign hyperplasia. So you mention it, but the majority of the time it's not going to preclude them from getting a transplant. The surgeon will do a biopsy, however, on the largest node to make sure it's not malignant if the patient has HCC. Okay, if you have portal vein thrombose, used to be an absolute contraindication. They've now been able to do some surgical procedures to get around that, and so it's no longer absolute contraindication. However, if it's chronic and the portal vein diameter is less than 4 millimeters, that is going to be a severe problem. It's likely not going to be able to provide enough flow to the liver to sustain the organ. Are there prominent varices? The only time this is really an issue is if it's pericaval or near the portohepatis, if it's right around the surgical bed, because it's an increased risk of bleeding. Celiac artery stenosis, you obviously don't want something limiting the arterial supply to the new liver that they transplant. So if it's caused by median arcuate ligament syndrome, then they just split the ligament. And if it's caused by atherosclerosis, then they'll usually try to create a different inflow from the mesenteric vasculature. Is there a splenic artery aneurysm? They're already going to be in there, so if there is one, it still has a risk of bleeding post-operatively, so they need to address it while they're in there. And this is not something that they routinely look at while they're in there, so you need to make sure to look at that and mention it. Is there a TIPS present? You know that TIPS can migrate if the superior end is projecting into the IVC. It causes a little bit of fibrotic scarring of the IVC and can make the anastomosis more difficult, so they will want to know that as well. So this is a diagram of the split liver graft. Split liver grafts are cadaveric, so the IVC gets taken out. Main thing to note, this is the lateral segment of the left lobe. This is the medial segment of the left lobe. You always want to make sure that the middle hepatic vein and the hepatic segment 4 artery go with the medial segment of the left lobe of the liver. It needs those things for that segment to survive. So sometimes they will transplant just the lateral segment, but if they're doing the whole thing, when you're describing the anatomy, you need to make sure that you talk about the origin and course of the middle hepatic vein and the artery supplying that segment. Okay, so on to living donor transplantation. I think that this is inaccurate. This is the one thing on this picture that I don't really like. They have the middle hepatic vein here, like I was just telling you, it needs to go with the medial segment of the left hepatic lobe, and they have it supplying the right over here. But anyway, notice that the IVC stays intact and it stays in the donor. And then you take this graft, and this is what it looks like once it's been placed in the recipient. Okay, so the preoperative imaging here, you must exclude diffuse and focal hepatic abnormalities, including diffuse fatty infiltration. This is in the donor. If they have diffuse fatty infiltration, they're going to get a biopsy to see how much. If it's 30% or greater, that excludes them from being a donor. You can try to estimate what percentage fatty infiltration they have based on the Hounsfield units. So approximately 40 Hounsfield units is around 30%, and 30 Hounsfield units is approximately 50%. But they're going to do a biopsy anyway, so you don't have to get that fancy. It's really important to do vascular mapping. They need to know exact anatomy of the hepatic arterial supply. Is there a replaced right hepatic artery? Is there a replaced left hepatic artery? Again, they need to know about the course of the segment 4 artery, which stays in the donor. And it's good to know that classic hepatic arterial anatomy, where both the right and left arise from the proper hepatic artery, that only occurs in 55% of the patients. So there's a decent chance that there's going to be some sort of anomalous anatomy there. Okay. So if there's atherosclerotic disease of the celiac artery in the donor, then it's a no-go. That's not going to happen. Let me get that. Okay. Third year. Which variant is this? Yes. Yes. So this is just a reconstruction from a CTA. All right, so looking at some venous anatomy, this is the portal vein. This is the normal anatomy, where the right vein is basically a continuation of the main portal vein, and then the left kind of branches off to the side. So it's more of a bifurcation, but this is a common anatomic variant where it's more of a trifurcation, and the dotted line here is where they would need to transect or ligate. Here's another variant where the right anterior portal vein comes off of the extraparenchymal portion of the left portal vein. So in this situation, they would have to ligate and anastomose in 2 different locations. It's important for them to know. In this scenario, you have the right anterior portal vein coming off of the intraparenchymal portion of the left portal vein. Also, again, important to know. So, venous anatomy, you can also have accessory hepatic veins. Here, it's most common in the right lobe and inferiorly, and this is a good example of that. And it's, instead of joining the right hepatic vein up here, it just drains directly into the IVC. Okay, so talked about diffuse hepatic parenchymal disease, and we talked about you can do the liver attenuation index. It's basically just taking the average of the spleen and the liver and subtracting the liver from the spleen. And if it's negative 10, wait, did I say that right? Average, take the average of the liver, it should be higher than the spleen, subtract the spleen. If it's negative 10, then it's approximately 30% or greater fatty infiltration. Or you can just use the Hounsfield units, but you don't have to get too fancy with that because they're going to biopsy. But for every 1% increase in fat content of the liver, there's an estimated 1% decrease in functional liver mass. So that comes into play when they're calculating how big of a graft to put into the person. Okay. And then you would want to use non-contrast CT, preferably. You can do it with contrast enhanced, but non-con is preferred. Or you can do chemical shift imaging with MRI. So just 3 examples of hepatic steatosis. Here we have ultrasound. You see you're losing the bright white of the portal triad fat because the rest of the liver is fatty infiltrated. Here we see that the non-enhanced liver is significantly lower attenuation than the spleen. And then here is in-phase and out-of-phase imaging. You see the India ink artifact, and there's significant signal loss on out-of-phase compared to in-phase, indicating intracellular fat. Okay, so then we need to evaluate the biliary tree. MRCP is a good way to do that. Sometimes they will do more than one of these routes just to make sure they have everything delineated perfectly. So occasionally they'll do ERCP as well. Some institutions do CT cholangiography where they administer oral iopanoic acid. I've never been involved in a case of this. Dr. Sangster, have you ever used this? I don't think we ever used it here. But you image 6 to 8 hours later. This is an example of that. Yeah. Okay, so then we get to volumetric evaluation of the potential donor liver, and you can do that with either CT or MRI. It's way easier to manipulate the data at a workstation on CT, or if you have fancy software with your MRI, then you can do it that way. Basically, the choice is going to come down to which one of your big pieces of equipment has that software, because otherwise it's going to be very time-consuming and excruciatingly painful. If you're trying to determine the volume of the right hepatic lobe, then you're going to want to go just to the right of the middle hepatic vein. So you want to do it based on the hepatic venous structures. So this is an example of that. They're basically showing how they did essentially a virtual hepatectomy or partial hepatectomy for the surgeon so they could see the volume of the segment. So going back to the protocols, know what to do if you have to evaluate one of these patients. If you're using CT, you need pre-contrast images to look for the fatty infiltration and see if any lesions in the liver are enhancing. post-contrast images of the abdomen, you're going to need an arterial phase at 20 to 25 seconds after the start of contrast administration, or you can do a smart prep of the distal thoracic aorta at about 180 Hounsfield units as your threshold. And then you do a portal venous phase 20 seconds after the arterial phase, and a hepatic venous phase 60 seconds after the arterial phase. And you need to use very thin slices and do multiplanar reformats of all of the post-contrast images. And yes. And then, use of multiplanar MIP images, 3D MIPs, and volume render. Or you can get together with your surgeons and see what they like. They're all going to have their own preferences, and since they're standing there for 12 hours over the patient, I usually do what they want. But okay, so CT versus MRI. The reality is, even if you get CT, sometimes you're going to still need MRI, and when you use MRI, sometimes you're still going to need CT. So in a lot of cases, you're going to be able to use one or the other, but there are also going to be several cases where you have to use both. So don't get too worked up about that. You need to do MRI, MRA, and MRCP. The MRCP is to evaluate the biliary structures. MRA, of course, is to look at the arterial anatomy. I still feel personally that CT, when you can use the hepatic venous and portal venous phases, gives you a better look at the venous structures than MR. I like the spatial resolution of CT for that. However, if you're evaluating hepatocellular carcinomas, it is fairly frequently that we'll find an additional lesion on MRI that we did not see on CT. And so, that can, of course, affect the Milan criteria and change the staging of the patient and bump them up or bump them down the list. So, let's see. So the strength of MRI is going to be your better contrast resolution, but it has inferior spatial and temporal resolution. And this is just my wordy conclusion. So if you work at a transplant center, the radiologists are a very integral role in the transplant team. But your guide is to make sure that you're getting the best images possible, so you have to talk with your techs and tweak things, sometimes based on your patients. If you have somebody with a ton of ascites, you may need to go drain them before they get their MRI. You have to think this is a very, can be obviously a life-altering surgery. It's not to be taken lightly, and you need to do as good of a job as you can to evaluate these patients preoperatively to give your surgeons a good roadmap. Let's see, and that's basically all I have. Do y'all have any questions or anything? When I do the dictation, I don't. I should. I always dictate in the same order, everything, and so that's kind of how I go through it. I have a template for my non-contrast chest CT nodule follow-up, but that's about it. But, so hopefully next year I'll have more interesting pictures in there. I haven't figured out how to capture images from the VA without Army men rappelling from the ceiling trying to arrest me. So I've already had one incident with an iPad, so. So, all righty.
I think
Y'all like that better?
Yeah.
With the questions? Okay. Next time we'll have more pictures, I promise.
For the living donor, maybe I missed it. Does the living donor with the residual left hepatic lobe, do they do a cholecystectomy on that patient too, or do they leave it kind of flopping around?
Well, it comes out with the right lobe.
Okay.
So, but they do not put the gallbladder in the other patient.
Okay. I mean, that's what I figured. I just didn't know if for some reason they decided to preserve.
I think the gallbladder goes in the trash regardless.
the
Yes.
recipient needs evaluation also, the CT triple phase of the liver?
That's a good question. I have never worked on a pediatric transplant case in real life. So I don't know what they routinely do at pediatric transplant centers. I would imagine that they would try to do everything with MR first, and if they're having issues with that, then they would go to CT. Alrighty, thank y'all.